this present morning. And as Professor Dr. Prakash Mehta pointed out nicely, it's been a strike day in the city, but still we have a good number of people who are really interested in preeclampsia attending. Myself, I'm Dr. Prarthana Shah. I have done my fellowship in fetal medicine after my gynecology degree. So I'm going to introduce all of you to this topic of changing trends in the preeclampsia. Now we know in the a very famous quote recently has been, "Who will survive and do well in this century is the one who knows how to learn, unlearn, and relearn." And since past 2 days, we have been all have been doing the same because we are into it. We want to learn new things and we want to unlearn the past things that we learned. So what we have been learning and what we may be looking today forward to is the new diagnostic criteria, starting from how to check the blood pressure properly, what are the new blood tests that are available for these screening methods, what is the role of ophthalmic artery Doppler, or the role of fetal maternal echos in severe preeclampsias, then various newer blood tests in the monitoring of the preeclampsia we have been looking at. Today morning, we'll listen to Professor Leona Poon when she again introduced some new molecules like inhibin to the screening methods. Yes, and then Professor Staff introduced us to the postpartum monitoring of what are the new techniques and how we can really follow up our women who develop preeclampsia. So let us see what our professors have brought us for us these newer cases, and through cases we will discuss these new trends in our scenario. So the first panelist is Professor Manu Vatish, who is MA, MB, BCH, DPhil, and MRCOG, and a professor of obstetrics at the University of Oxford, Deputy Director at the Maternal Newborn Child Health, Bill and Melinda Gates Foundation. And we have listened to him also yesterday with the new molecule that he discussed yesterday. And he has many awards and honors, including this Fulbright Distinguished Scholar UK to USA, Churchill Fellowship, Health Science Journal Healthcare Award, and Univants of Healthcare Excellence Award. And his area of interest is, of course, preeclampsia, and that's why here he is all the way from the US. Our second moderator is Dr. Ramani Devi, and our second moderator is Dr. Ramani Devi, who is MD DGO FICS and FICOG and a consultant obstetric and gynecology, director of Ramakrishna Medical Center and Janani Fertility Center, Trichy. And she's a vice president of FOXI 2020. She has a number of publications and presentations to her bag, and many awards and honors and achievements. It's a big list, ma'am, really, to read all these. But yes, there are many gold medals, FOXI awards, IMA awards, and her area of interest, apart from preeclampsia, high-risk obstetrics, and ERT are there. Now let us come to our panelists. We are our all beloved Mrityunjay Billard sir, who is a professor and senior consultant. And again, he has many awards like Newton Baba Award and the Kelly University Best Teacher Award. His area of interest are obstetric hemorrhage in especially PPH and community health educations. And we all know that he has been working hard in these preeclampsia neuromolecule screening methods and various molecules in that. Again, he's written many books and many publications at national and international levels also. Our second panelist is Dr. Sadhana Gupta, who is a co-chair of SAFOG NCD committee and vice president of FOXI 2016. He's a director and senior consultant and IVF specialist at Jeevan Jyoti Hospital, Gorakhpur. She has many publications, almost 15 research papers, and many presentations at national and international levels, many orations and keynote addresses. She has been awarded and honored with many prestigious awards like FOXI Representative to SAFOG, Vice President of FOXI, and many others to her list. And her areas of interest are high-risk obstetrics, fetal medicine, and infertility. Our next panelist is Professor Peter von Denilson, and he is working in UK as a professor of global women's health at King's College London and honorary consultant obstetrician at King's Health Partners UK. He has 443 publications and presentations, which are more than 200. The number itself will tell us what we are looking forward to here. And his area of interest is global health and translational science and placental disorders, which we know is very important for preeclampsia. So now I request our moderators to start the sessions.
Yes, sir. Good morning, everybody. It's really a proud pleasure to be a moderator in this very, very August international conference on hypertensive disorders. And with me is, I think, my all my co-moderators and the panelists have been introduced. So basically, I have prepared this based on the guidelines by hypertension guidelines from Canada, ACOG practice guidelines, and again, in a NICE guidelines and FOXI ICOG guidelines, which was they developed when we were in the FOXI as office bearers. Again, ISHAP guidelines, hypertensive disorders of pregnancy, mainly all these things were being taken from this thing. So as an introduction, HTP is the most common medical complication, and India, 12 to 22% of the women, they do have hypertensive disorders of pregnancy, and the incidence of preeclampsia in India is found to be 10.3% according to the National Eclampsia Registry in 2013. And why we are so much bothered about hypertensive disorder is that we know that maternal mortality is very high, and it ranks the third one. We are now probably comparatively, when we see the maternal mortality due to PPH and hypertensive disorders, it is gaining a momentum higher up, and more than 70,000 maternal deaths each year worldwide, and when it causes more than 500,000 fetal and neonatal deaths also. So ultimately the burden of health system is being very much high because of this. And if you see in Asia, postpartum hemorrhage followed by hypertensive disorders and sepsis ranks the common one. Now let us see what the ISHAP classification says. Anyone of you, can you share that? Can you put off the light there, sir? Mike.
Chronic hypertension, and then pregnancy specific hypertension. There we have gestational hypertension, the preeclampsia. Even it is including the atypical type of preeclampsia, and chronic hypertension with superimposed preeclampsia. These are the broad classifications of ISSHP, but there are certain other definitions, like, there is a masked hypertension, the white collar hypertension. So all these are some of the other hypertensive classifications are included in this ISSHP classification of hypertension in pregnancy.
Anybody wants to add up anything to this?
Just one thing, because gestational hypertension, pre-existing and preeclampsia, we are aware, but just one point, this is very important, that whenever there is even the white coat hypertension, what we say that hypertension at clinic but not at home, or the delta hypertension, that suddenly there is one peak of the high blood pressure, or the masked hypertension that normal at clinic and sometime abnormal at home. These patients also are to be looked carefully, because they can have the more chances of developing hypertensive disorder and the preeclampsia. So always our patient says, no, it is only in your clinic, I am perfectly okay. Just one point, that they must be followed up very closely, because they have.
So the message is, once when you detect hypertension in any pregnant woman, she has to be followed throughout. So then, what is early onset preeclampsia and what is late onset preeclampsia, and why we are more bothered about classifying them according to the gestational age? Yeah.
When we talk about early onset preeclampsia, it is before 34 weeks of gestation, that obviously after 20 weeks, and late onset is beyond 34 weeks. Normally, we know usually if hypertension develops, it's usually after 34 weeks of gestation. But early onset, again, it has more effects on the mother and the fetus. Even whether it's growth restriction or maternal complications are more severe when it occurs in early onset, because the exposure is more, unlike in late onset. Usually by 34 weeks, after that, if she develops hypertension, growth restriction will not really occur. So that may cause only some kind of oligohydramnios, but whatever has happened will be more with the complications and severity is definitely more with early onset.
Sir, you want to add up anything, sir?
Well, I just wanted to ask a question where the burden of maternal mortality is in India. Is it in early onset or is it in late onset?
It is obviously in early onset.
Actually, it's probably not true.
Oh.
Okay, so we had a very careful look. No, South London, so it's not the same as India, clearly. So 80% of preeclampsia arises at term.
Be honest.
As an individual woman who develops preeclampsia, it is more dangerous to you if it's of early onset. But at a population level, at a health system level, especially when you've got scarce resources, the burden of adverse maternal events occurs at term because 80% of the disease occurs at term. So there's been, I think, an unfortunate focus on early onset disease over about the past decade. And and people have been ignoring the bulk of women who develop the condition. The biological process involved with early onset preeclampsia is probably nearly always imperfect placentation and the angiogenic imbalance story. And I, as I trained in the same shop as Manu, I'm also a believer in the exosomes and the microparticles. However, at term, it probably more reflects the underlying maternal diathesis towards preeclampsia, but you're more likely at a population level to die at term. And adverse perinatal events are not that much less frequent with term disease at a population level.
Yes.
So we have to remain very aware of that burden of risk for women, because if we ignore that risk, some of them will die.
So I agree very much with you that early onset is more focused. But I also said that usual occurrence of hypertension is after 34 weeks. And we have an advantage that if we diagnose hypertension after that, we are more towards termination and maybe avoid the risks which we can really have with the baby or the mother. That is the biggest advantage after 34 weeks.
Actually, when we are considering, because this session is for the low middle income countries, so 34 week very rightly said that the majority of the population wise, the term or near term preeclampsia is much more common. The important issue for us is that what is the goal of the treatment of preeclampsia? Termination of pregnancy when we have the complete restoration of health of mother and neonate. So in our setting, the important issue what we see in early onset is we can deliver the timing of delivery, the baby are premature, and they don't get that good neonatal facilities for a long time. And that's why the early onset become a real tricky issue, that how to manage expectantly and improve the neonatal, the outcome of the management.
So can I ask a question? In the registry that you mentioned, is there a breakdown of what gestational ages that the women are delivering? Because that would probably throw some light. Usually obstetricians are really very focused on babies between 24 and 32 weeks. That's where we apply a lot of focus. We scan them, we identify them, and actually once they get to 37 weeks, we kind of lose interest in our patients. In a negative way.
No.
Deliver, that's all.
You know what I mean? We sort of sit there and our foot is slightly off the accelerator or the brake because we think we made it. So I'm just wondering if there's a distribution, if it's known what the distribution is.
From obstetrician point of view, we are more concerned about early onset because as you rightly mentioned, but more importantly, in late onset preeclampsia, you would have said to the woman that you are fine. So by the time she comes with the next week follow-up, she has come with severe features, or at times she throws the convulsion. The person who was normotensive a week back comes with either eclampsia or severe features of that. So that worries about the late onset preeclampsia. Whereas early onset, we are more worried about the survival chance of the fetus or the baby. That's the message from the obstetrician point.
Okay. The next question is focused to you, sir. It's regarding the pathophysiology. Being a senior person who does a lot of work in placentology of preeclampsia, I think you can enumerate why do we get it, and then what is the basics of
Okay. So thank you for putting up the slide, because I never want to see it again. Right? Late onset preeclampsia has this placenta. It is normally formed. It's 80% of the condition we are meeting to talk about. Has a normal, completely normal placenta initially. Early onset preeclampsia has this placenta, by and large. And clearly you're going to have some mixed stories, but this image is shown in lots of talks. And I really hope never to see it again. Because we are leading people down a blind alley if we're only focused on this. So if you consider the process of developing preeclampsia to be a mismatch between the ability of the mother to perfuse the placenta and the fetoplacental demands, so therefore macrosomia at term, for example, or a multiple pregnancy with a normally formed placenta, then you'll end up developing acute atherosis, and the other consequences that will then lead to ischemia, reperfusion injury in the placenta, and an accelerated placental aging. Sorry, Manu, you want to say?
So I do think it is an important diagram, Peter. It may not be the complete diagram that's required. So I think the core feature for preeclampsia is syncytial trophoblast stress of the placenta. And that stress is driven by two predominant drivers. One that drives early onset disease, and this is this malimplantation, then you get reactive oxidative stress. You stress the placenta releases stress markers like soluble FLT. You also have pathogenesis of late onset preeclampsia. In late onset preeclampsia, the placenta is almost a victim of its own success. And in those placentas, you've got almost the villi overcrowded. And so what you're doing now is you've got, rather than not enough blood coming to a placenta, you've got not enough space for the blood to get adequate exchange to the placenta. And that causes syncytial trophoblast stress. And that also causes an elevation in soluble FLT. And if you were to look at the course of normal pregnancy, just normal, and you look at the Levine paper, Anand's paper, you see that soluble FLT, as you get toward term, just rises. And if you look at the PLGF, it just falls. And actually, what that's telling you is the placenta is just getting stressed. So I think that what we need to do is be cognizant of the different pathophysiologies. So I agree that this diagram on its own makes Peter anxious and a bit sweaty and he doesn't want to see it. But if we could have the diagram on this side and the diagram on the other side saying late onset disease, actually it all ties together to syncytial trophoblast stress. And that tells us where we need to focus our attention in terms of diagnosis and ultimately therapy.
I just want to say one more thing. I mean, one of the features which is lately removed is the growth restriction. We've also seen patients who have growth restriction and slowly towards term their BP goes up. So what he's saying may apply to it, that placenta still plays a role even in late onset preeclampsia.
There's somebody at the back there.
Differentiation from the apparent presentation, as we call it, and potentially lead to both early or late onset preeclampsia. And I also wanted to add, for the late onset preeclampsia, there is a lot of evidence emerging to say that the growth of placenta is impaired, whilst the development is fine. The growth of placenta and, of course, the underlying endothelial dysfunction or vascular dysfunction is more important than the trophoblast function.
I agree with you, and there's also other features. You know, there's placental aging, and then there's mitochondrial function. The main problem is that we just need to recognize there are different pathological processes that converge on a common output, and that common output is you have high blood pressure, you end up with this sequelae, this conglomeration of symptoms that is being driven by different pathogenic processes.
Sick.
Yes, absolutely. I agree.
Keep the mic close to them. Okay, let us move on to the next. So what are the systemic manifestations of why we are so much bothered? if a patient has got a preeclampsia or a hypertensive disorder, how it is going to affect her?
See, preeclampsia or the hypertensive disorder is a multi-system disorder.
Systemic intervention.
It's a manifestation of this is one component is blood pressure, but the disease process is already involving all the systems of the body. It doesn't just affect what we were thought of earlier: kidney, CNS, liver, blood. See, all systems are involved in this, and that is why it is very difficult to evaluate by one angle. We need even the cardiac system is now, because it is not mentioned, but there is a type of hypertrophy which occurs in preeclampsia with the related to heart. Normally there is it is abnormally in preeclampsia, concentric hypertrophy happens, contrary to the usual, the hypertrophy of the heart, that reduces the cardiac function, and that adds risk to this. And then the liver, of course, all these are known factors, kidneys, and for this gathering, I don't think we need to add anything. But most importantly, it's a multi-system disorder. We should not be looking only at hypertension as the only marker here. So we need to look as a overall, the holistic approach is very, very important in evaluating, managing, and diagnosing and treating.
Yes. So
just before you go to the cases, that because everything take first, the high blood pressure is the first thing which we say, and then we go to the systemic manifestation. But preeclampsia can be a very good mimicker. So we have to be careful. Isolated IUGR, then the isolated organ dysfunction, even without what we say 140, 90 or 135, 85 blood pressure we have. And this is something very important again for for our country setting, that we must be very, very careful about the atypical presentation when we can have a serious complication even without what is the standard definition of hypertension.
Thank you, madam. So the first case is a 24 weeks primi gravida. She's 26 years. She reaches a district level hospital, and there the recording of the BP was 150/100, and she did not have any other problem. And how to proceed with this patient? She is 24 weeker.
You're talking from the low and middle income country.
Yes, I am telling you, she is in the district level.
No, but there are high income people are sitting. So that in that context, whether the question. Yeah, that's why I want to say that. See, the very first important message is that the patient has come there with 24 weeks and the blood pressure is 150/100. So first question is, was he diagnosed first time hypertension? Was it the diagnosed?
We can't expect that in the
if she had earlier visits, whether she was a normotensive. That's number one. And then this patient, because at district level, these facilities looking at excluding, I think in Tamil Nadu, in most of the other states, I'm talking Tamil Nadu is little different as far as the healthcare system is concerned, because they are doing even echocardiography for all the pregnant women. So you are a little bit ahead, madam. I'm not talking about the Tamil Nadu, but rest of the country. District level hospitals are not very well equipped with all the facilities. So I feel that this case, it's an early onset hypertensive disorder. So she needs to be properly evaluated with all angles. She needs to be referred from there to a multi-speciality care, tertiary care or quaternary care hospital.
So you want to send her immediately, or
no? We need to do certain basic things which are possible in district hospital. Okay. But as far as the management and further treatment is concerned, she should be referred to higher place.
We can do district hospital is fair, Anna, because many country out of our district hospital are being turned into medical colleges all over the country. I think this is the thing. So it is first thing we have to, this patient can be admitted at district hospital for a day care and do all the necessary investigations. So that first we have to think that it is a gestational hypertension or it is a preeclampsia, and that can be I think this can be taken with the district level, because anyway if we are referring, they are doing. Yes, for the higher marker, if we say any biomarker, then it is something different. But to me, the indoor admission and confirmation of the preeclampsia vis-a-vis gestational hypertension is something we can do, and we can like tell all the plans to our this patient where she can go with this.
Yeah, in Tamil Nadu, almost all the districts we have a medical college, and even in the primary health centers, when these patients are booked antenatally, they are advised echocardiography. Probably they are suggesting in the second trimester, but I would rather prefer it should be done in the first trimester. The reason I'm giving is, one thing is we can pick up early onset of chronic hypertension, which will be found in the echocardiography of increased LVH, or sometimes we can pick up a cardiac disease which is incompatible with the subsequent with the continuation of the pregnancy, which can be terminated. So that is what is happening in Tamil Nadu, and all the primary health centers at the first level, they are doing basics, like they do the BMI, and the risk score assessment is given to them. They have the chart. So immediately they will put it there. And then they have the blood pressure that is being monitored. SaO2 is monitored, urine albumin is checked, and CBC is done. So these are the things that are done at the primary health center level. Okay, then for the echocardiogram, what they do is they collect the people, and either the person comes from the district level and does it in their own place, or they are referred. So this is
the first trimester echo 1, and second, what have you discovered by doing first trimester echo?
Okay, so
find any abnormalities you wouldn't have found?
Yes.
Yeah, so I mean, I think a first trimester scan is really helpful. So the first thing I was going to say with the previous slide is, how certain are her dates? Because I know India has introduced ultrasound, but most of your colleagues in the subcontinent and in sub-Saharan Africa and Southeast Asia, women book at 24 to 28 weeks, and that's the median gestational age for booking. India is very different. It has a privilege, clearly with a south to north gradient about the use of ultrasound, but dating a pregnancy early, but by sorry.
See, echo, the reason why I am advising in the first trimester is
that's a very expensive test to be doing on every woman.
So it is done free of cost in Tamil Nadu.
But somebody's paying their taxes for you to do that. So so at a health system level, so I think dating the pregnancy. So in the PRECISE network, for example, if we accurately date pregnancies, we reduce the burden of preterm birth by 20%.
Yes.
Those small babies are now recognized to be growth restricted or small for gestational age. So having ultrasound dating I base all of my care around that certainty of an EDD. Secondly, somebody hopefully is going to say, let's give her some methodopa to bring her blood pressure down, irrespective of where she is in the health system. We did it successfully with community health workers not far north from here. She needs to have her urine dipped, because if she has 2 pluses of proteinuria, she will have a positive 24-hour collection, though hopefully no one's doing those anymore, or a positive protein to creatinine ratio. Yeah, so a dipstick of 2 pluses, 1 plus, the problem is you get false positives with a quite high rate. But if you've got 2 pluses, then you've made a diagnosis of preeclampsia. Or if she has headaches, epigastric pain, blurred vision, by the new ISSHP definition, which has also been picked up by NICE, she has preeclampsia, even if she doesn't have proteinuria.
Proteinuria is not very significant. Yes.
Yeah. So so there's a lot that can be done at any level of the health system, and that will help you make a decision. But if you make a diagnosis of preeclampsia, on average, she will be delivered within 2 weeks. irrespective of the health system. So therefore, she needs to be referred because she's got a very preterm infant, in my opinion.
Just one point about the echo discussion which was happening is routinely it is currently not recommended anywhere, but what we have done our study in preeclampsia and controls, but it should be beyond the circulatory volume when it increases. That is where the burden, beyond 8 weeks onwards, the blood volume starts increasing. It reaches the peak.
See, I agree, sir.
That is the point. Why? That's why we are telling late in second trimester would be advisable if we are practicing routinely. Currently, it is not recommended, and we are not endorsing that to be done. But we have done a diastolic dysfunction in echo with the matched controls. We had the preeclamptics and eclamptics and normotensive. We found that more than 60% of the preeclamptics had severe form of diastolic dysfunction, contrary to the normotensive, which the manuscript is ready. We are getting it published, which will get published soon. I have shared with Peter on that.
I totally agree with you, sir. For hypertensive disorders, you do it in the around after 24 to 26 weeks. But in order to identify the underlying cardiac disease, it is better. That's the only reason why we should do it in the first trimester, because termination becomes easier.
If there is a clinically symptomatic person, you have got to.
Can I just share my experience in this? Why Tamil Nadu has brought in this is we've had maternal deaths where they found no cause, and apparently they were thinking, could it be some kind of. We have a lot of maternal deaths where we are not able to identify the causes. In those cases, it's sort of you screen women. I don't know how long it will sustain, but that was one of the initiatives by Tamil Nadu. Let's see what will be the results. So,
that I agree.
True, ma'am. Very true, ma'am. What you're telling is very true, but we have to understand that. Even in clinical examination, people are missing out on heart disease and things like that. That's where all these things are coming up. And now it's more like a defensive thing. That is becoming a... From the cardiologist, it was mainly because of the maternal deaths. They have a very good system in Tamil Nadu because most of our patients, even in Pondicherry, come from Tamil Nadu. They have, this maternal audit it's very robust. It's not just at one level, it goes at 3 levels. So at all discussions, this has happened. And that's
so you say something.
So just to get back to this case, I think the first thing I'd want to do is just make sure that she has raised blood pressure. Yes. So we've got a single reading. Do we know that she's got white coat hypertension? Do we know that she had her blood pressure done correctly? So I'd want to just double check her blood pressure first.
Yes, I put the slide just to know how to take a proper blood pressure. Okay. Then,
so do you have liquid crystal splits?
It is said that we have to do it, but we very often do it only with the mercury sphygmomanometer or with the...
We have done with digital. Which are standardized. No
one's currently...
Australia will have some because that's where Mark's done the work.
I'm talking of Indians. In Indian context or low and middle income countries, we do not have that liquid crystal. But I want to share with you, in our CLIP trial, we use the MicroLife device, which is semi-automatic, and with the traffic signal type, wherein it can diagnose based on the shock index, even the hypotensive shock as well as hypertension, red light when it is above 160, and the yellow light between 140 to 160, and green light if it is less than that. This was an amazing help to the ASHA workers who did this community level intervention to identify this and take the patient. If it is a red light, they used to give methyl dopa and also take this woman to A&M to give a magnesium sulfate and refer to the higher centers. This MicroLife device, which is supposed to be at $20 to be available in India, but still it is not coming up because of some technical hitches on that.
Magnesium sulfate at home.
No, A&M. They are taken to PHC or nearby and then given by.
But in the other two countries, Mozambique and Pakistan, the community health workers administered 10 grams of intramuscular
Yes.
magnesium sulfate in the women's homes to overcome the 3 delays. But we only gave about 20 doses. We hurt a hell of a lot of oranges training community health workers to give intramuscular injections because that's the best way to. So I'm not sure I would do it again unless a woman was really remote.
So
I think
that has one advantage is giving labetalol. See, in Tamil Nadu, they give labetalol, primary, the ASHA worker or the primary health center level, then plus magnesium sulfate, 5 to 10 grams loading this. They immediately transfer the patient to the higher center.
Right. So for your health system, the labetalol is going to cost 10 times the amount of as methyl-dopa, and it's no more effective for chronic or gestational hypertension or preeclampsia. And if you give a loading dose, you can bring the blood pressure down very quickly. Well, there's no urgency. It will come down in a smooth and careful manner.
Methyl-dopa, we do. Oral tablet, not IV.
No, I know. I haven't used an intravenous medication for severe pregnancy hypertension in 20 years if the woman's been awake. If she can swallow, I always use an oral medication. I never use an intravenous medication because it's quicker, it's cheaper. It actually, because all the delays in drawing up, administering, getting a doctor to give the IV drug, that can be a 1 to 2 hour delay in a busy health system. Give the oral drug. It's been on board for 2 hours before you gave the first lot of intravenous. So, there's a lot to unpack.
So that's what we are telling in a community level. Give an oral dose of labetalol and start Maxil if the BP is going to be higher like this, and then refer to the.
So if I'm your Minister of Finance,
you won't give me the money. But magnesium sulfate is very cheap, so we can still give.
No, he's talking about labetalol.
Yes.
I just want to inform that labetalol is not a new drug. Please understand.
Yes.
It came in 90s, and because of its ineffectiveness, oral, it was withdrawn, and we moved back to the nifedipine and the methyl-dopa drug. And now the oral dose, and what doses they are giving the practitioner, it is very sad to note that 100 milligram BD, 100 milligram TID, it will not be, it's a pediatric dose, what I say that. So we should think, and one is, there are certain criteria to follow to use of hypertension, antihypertensive drug. Methyl-dopa, because we took the ASHAs in consideration in the study, and we gave the methyl-dopa 750, which is, the 3 times the dose. By the time the woman reaches the referral hospital, her blood pressure would have been come to near normal. Sir, and the magnesium sulfate is being given there, and that prevents the occurrence of convulsions. That's the only objective of this in community level intervention.
Yes, but is it available, sir? Methyl-dopa is not available.
It's not available all over country now.
Because all of us are done away with methyl-dopa, unfortunately.
No, we have not run away. Pharma people have withdrawn. No one of us have run away from that. It is a pharma people who are not manufacturing.
Yeah.
Costlier drug. Nobody have. We all like it. We all remember it. Our generation likes it, madam. Current generation, no.
Sorry. Could I?
It would just be sensible if everybody spoke one at a time. Yeah.
Sorry.
Okay.
Two things. This was supposed to be an LMIC session, not an India session, though I recognize that nearly everyone in the room is Indian. So we're dropping into a very Indian specific discussion. And so therefore you have to remember, in Brazil, they don't have labetalol. It's not on the pharmacopoeia. National Pharmacopoeia. So they've got to choose something else. In Fiji, it's just too expensive to use. And so they'll use propranolol, and that's fine. So we just have to understand it's the approach, and the specific drugs and the drugs that you're comfortable with are the ones to use. But in a highly stressed public health system, you have to be able to justify to me as an external observer why you're choosing a more expensive drug. Professor Munle did the trial in Nagpur, which showed that methyl-dopa is very effective even for severe hypertension in pregnancy, generally. So why choose a more expensive drug when you've got a cheaper drug? I mean, I just don't understand why why that choice would be made. There's a gap in my understanding for making that decision.
Madam, Lata Madam, can you tell, suppose, what are the investigations that can be done to confirm which type of hypertension is that?
So
each level.
Yeah. So with a BP of 150, 100, we repeat and see if it is persisting. Anything beyond 140, 90, we do need to know whether other systems are involved, because our ultimate aim is whether to continue pregnancy or terminate. So I would like to do a hemoglobin and the peripheral smear and also the counts, because most of them may have microangiopathic hemolysis. The next is the liver function test, because if enzymes are elevated, then of course we need to think of termination. Of course, I forgot about platelet count. So platelets are very important. So these are the things. And other than that, we have to look at the renal function. Creatinine is better to look at. So again, and in liver function, specifically bilirubin levels and the alkaline phosphatase and SGOT and SGPT. These things which we look at. And yeah, urine protein definitely yes.
Madam,
See,
my the first level.
Yeah. What I wanted to say here is we are talking so much about hypertension and severe, non-severe, whatever terms were used earlier. Mild hypertension is something like non-severe hypertension. So proteinuria is a must. That is a basic thing. If it only proteinuria is there, we'll obviously think of non-severe. If it is anything beyond that, whether clinically she's having pulmonary edema or renal failure or investigations wise anything is elevated, then we'll label them obviously as severe hypertension.
So many webinar in informative days.
So
like we are, like now people is saying no urine protein, they are not at all focusing, and it is like Dr. Ballard that the marked sphygmomanometer urine dipstick test can be done then and there. And if it is a 3+, this is the thing that we are making the instant diagnosis at any point, 24/7 days. So something which our like young clinicians are totally forgetting it, and it is not mandatory for diagnosis, but it is add on to diagnosis.
No, somehow the definition is taken that the proteinuria is not necessary, but which is not correct.
Yeah, actually, to understand very simple, we need to divide the specific to the hypertension related and the other system involved. So what we put it as PIH profile, you can do coagulation profile, health profile, and then the other investigations. Apart from urine routine, it is protein which is done, but it is maternal specific. There are fetal specific investigations also need to be done, and that will help, in the overall management of the case.
I think we have discussed enough about this echo.
Yeah.
Let me move
Ma'am,
on.
one more thing is even about fundoscopy, which is very important, which we thought.
I've come to that. Fundus and additional things have come. Now, what about you started that fetal thing has to be evaluated. How do you evaluate the fetal status in such patients?
See, first he mentioned dating scan and that accurate gestational age. It matters first. And secondly, whether it is corresponding. So we look at the parameters, which will give us the gestational age and whether there is any growth restriction, number one. And growth restriction, we also look additional features of the amniotic fluid. And then most importantly, which helps in the management is Doppler. So Doppler evaluation, we need to go systematically. I think that itself is a question to answer on later on, I think.
So first trimester screening.
That in the first trimester, we are talking after this case has come. So, but if you are looking at the screening point of view, then we need to look at the mean arterial factors. Of course, there are gestational preeclampsia scoring systems which we need to adopt the BMI, age, and other parameters. Apart from that, mean arterial pressure and uterine artery PI to be seen, and that will help the score whether this patient is high risk or low risk at the first visit or at 12 weeks.
So, being a lower middle income group, are we happy with just screening in the first trimester only with the basic risk factors, mean arterial pressure and the uterine artery pulsatility index? Or do you want to add any other thing?
Yeah, so there's a way of working towards the full fetal medicine foundation model, which is relatively cost effective. So if you just use maternal characteristics and blood pressure, you can appropriately reassure 30% of the population that they are low risk. 70% then need either placental growth factor or uterine artery Doppler, depending what's easier in your health system. And then you can do contingent screening again so that 30% will go for the final test, whether that's PLGF or Doppler. But that's probably okay in India.
Yes.
In Africa and other, in sub-Saharan Africa, North Africa, much of the Middle East, through the rest of Asia, that's just not, in the Pacific Basin, which is where I'm from, that's just not going to be practicable. So, developments like the RONIA platform, though it doesn't have the sensitivity yet officially to go down to the end of the first trimester for PLGF, may provide the perfect solution because the whole blood point of care test using like a glucometer. So that will be a way to democratize that level of screening. And I'm not sure that many of our colleagues in the rest of the low and middle income countries outside India and maybe parts of Brazil and parts of other countries will ever, are going to have access to uterine artery Doppler in the next decade.
He wants to add something.
Yes.
Please.
You're audible anyway. Carry on.
Hi, so I work in Zambia, and one of the things that I'm very interested and curious about is how to make the best use of a late stage, late trimester, late second trimester or third trimester ultrasound, because what will happen is that people will perform that ultrasound. That might be the only ultrasound that a woman has, and then we'll start making clinical decisions we'll date a baby based on that, even though we know that that's not going to give you an accurate date. And they are going to start using that information, making decisions on it. And what's the best way to use that information, which people feel compelled to use because they have it?
So there are a couple of things. So if it's early onset hypertension, the fetus may well be growth restricted. So you're going to inaccurately date the fetus if you use 4-factor biometry, so including femur length and abdominal circumference. I'm a great believer in the transcerebellar diameter for a couple of reasons. One, it's really highly conserved between fetuses. And the other thing is I'm a simple obstetrician. At 24 weeks, the transcerebellar diameter is 24 millimeters. At 30 weeks, it's 30 millimeters. Even I can remember that when I'm on labor ward at 2 o'clock in the morning. So, and also if the TCD starts to shrink in most LMICs, that fetus will not survive. It's going to have severe early onset growth restriction and will not survive the neonatal period if it's not stillborn. So I would focus on the head because you have head sparing, and particularly the transcerebellar diameter using the intergrowth 21st charts. Yeah, but if you're I mean, the integrate charts there, but if I'm on call, I mean, in a digital area, you can probably look it up, but I would use the TCD as well as the other head biometry first.
Okay.
Is an anomaly scan done at 19 to 20?
No, Zambia. But the one thing you need to take TCD, it is technically a little cumbersome to do it. And if the woman is in labor also to do TCD, because just we have concluded our labor study, lowering adverse birth outcomes in resource limited setting, wherein all patients who come in labor room, we were trying to do that. It's TCD is not easy to perform for every common obstetrician. And as it is rightly pointed, it can, if they are doing at 28 weeks, TCD is the best. But if it is beyond 28, the question mark about that. But what is important here is look at the amniotic fluid. And amongst that, SDT, single vertical pocket, is more preferable than to amniotic fluid index, because subjective it is amniotic fluid index. But if we are having the Doppler normal, amniotic fluid is normal, this fetus is relatively normal at this period of gestation. Whether what is the gestational age, dating scan is not available. So we need to look at their LMP related data. So that's one point I just want to add.
Okay. So the Bill and Melinda Gates Foundation is investing quite heavily in point of care artificial intelligence based ultrasonography. That's accurate all the way through to 28 weeks at this moment in time. It doesn't require a skilled operator. I have seen it used, and it is deployable. We're about to deploy those devices in Kenya, South Africa, and Ghana. And I think that as that technology moves forwards, it will just become very cheap, become point of care, and that should help as far as gestational age dating and assessment of parameters is concerned. I think within the next 5 years.
I think this is what we are doing. It is done with the Gates Foundation only, that labor's trial, wherein we are taking 3 vertical sweeps and 3 transverse sweeps are taken. Right. And probably it will calculate that based on that AI, which is going to be used. And that's one thing which is planned.
Yeah, absolutely right. So the labor study did use the Jeff Stringer calculation.
Yeah, same. We are
but there are other platforms. There are another 2 AI platforms, one of which is being developed by Philips and another one developed by another company, all operating on different machine learning, all highly accurate. The 3 sweeps outperforms human sonography. I think you guys have got a poster on it in Figo. So I think this technology will democratize ultrasound, because it should be possible for the person, their first presentation, for somebody uninitiated to get a gestational age from that patient.
Yeah, that's a thing which is going to come up shortly.
Okay, so to summarize,
GE is the another company which actually came and approached us for this ultrasound related things.
So to summarize that first patient at a district level, I think she can be managed very well with the antihypertensive drugs, provided all the basic laboratory investigations are normal. And then we need to, do you want to ask her to go home and come back, or you want her to get admitted?
In the context of an LMIC, where she may not get recurrent permission to leave the family home because she needs a proxy decision maker, because she doesn't have autonomy of decision making, or various other factors, if she has preeclampsia, 1 at 24 weeks, I would refer her to the level 3 or 4 unit, because that baby is going to be born preterm. And you don't want an ex utero transfer, you want an in utero transfer. So I think that's really important.
So not only that, the question of how many babies with 24, see, maybe we can prolong her for a period of another 3 to 4 weeks, not beyond that.
No.
So how many of the babies with less than 26 to 28 weeks are going to survive in our setup, NICU?
So that will depend So if you're in South Africa, or if you're in the Western Cape, which is almost the Republic of the Western Cape, it's so different from the rest of South Africa, that baby has a reasonable chance. Sorry, the thing I didn't say before is give steroids. Give steroids for accelerated maturation of the fetal lungs, and it can be repeated once. So others may disagree, but I am a firm believer in that. I grew up in New Zealand. Mont Liggins had dinner in my house when I was a child. I believe in Liggins and Howie. So that's another component. So it depends on your health system. So what the current ISSHP guidelines say is the woman is pre-viability according to your health system. That may be 28 weeks, it may be as late as 30 weeks. Then you should offer termination of pregnancy.
That's the point I wanted to bring out here.
But that's health system specific. We're now resuscitating babies at King's College Hospital in London at 22 to 23 weeks. Right? So the viability has dropped down during my career from 24. I mean, I've been in practice for almost 40 years. I mean, it's come down by 2 weeks. But that really matters to some women and their babies because the intact survival rate at those gestational ages amongst survivors is as good or bad as at 24 weeks.
Actually, at this moment, just to say that this pregnancy is not going to go beyond 15, I think it is because nobody can predict the progression of disease. It may remain like this and we can go up to the 30, 32 weeks. So it depends upon everything about the fetal surveillance, about the organ dysfunction, because actually the problem with preeclampsia is that nobody can predict that with what will be the progression. So let's be open to everything. And in India, we really have the actually accessibility to good neonatal health care. If IVF pregnancy, they are like sometimes they are poor and old, but they really get the good neonatal. So it is not a one system in India. We have a very highly and sometimes the lower middle also access very well to the good neonatal.
One message I would like to give here is India is having at one go UK, America, Australia. At one end, we are having worse than Sierra Leone, where it is highest amount, because our population is really of two types. At one time, we need to care what is happening at your place or US. At another time, we need to be, that what I want to convey here is that we need to be, the requirement based and where we are working. So that decisions can be like what you suggested in low and middle income countries. We have to ascertain what is the pre-viability level and then decide the management. But one message also I want to give here is that we noticed one case of absent, recently twin pregnancy was there. One of the baby was having absent diastolic blood flow and reversal of blood flow. And we tried to say that the other baby at least should survive. So we left it, believe it, after 3 to 4 weeks also, the other baby was also born alive. So that is why we never know what is going to be right. We predict all this. Predictions can be wrong.
You go first, Manu. Okay, so there is an objective way of assessing maternal risk in low and middle income countries. It's called the Mini-Pair score. And it was developed and validated in it was Pakistan, but in South Asia and Central and Southern Africa, South America, Fiji, and it accurately assesses the risk of an individual woman to have an adverse event in the next 48 hours out to 7 days. So that there is actually an objective measure, and if you have access to laboratory tests, you can then use the 4-pairs model. That's about to be replaced with an AI-based version that automatically adjusts for your health system, called Pairs ML. So there's an ability to assess maternal risk, and so if the woman's got a very low score, you can appropriately reassure her that she'll probably be fine. And if she has a high score, irrespective of gestational age, she should be delivered. I mean, I think we have moved on.
Sir, you want to add anything about this PLGF test?
Well, I mean, there was a clue on the slide. So there are useful, these androgenic biomarkers are also quite useful. I think combined with mini peers, I think there's no single solution that you're going to use as a primary guide to how you're going to manage patient. I will say, and I like Peter very much, but there is a lot of evidence suggesting that repeated doses of antenatal corticosteroids may have some adverse impact on the neonatal brain.
Yeah, so the follow-up from Max would not agree in terms of school performance. So the brains are very slightly smaller, but you're more likely to survive. So, do I want a child who may end up being a plumber instead of a doctor, or a child whom I buried at 7 days of age? I mean, so we have become reductionist, I believe, about the use of steroids. We tend to hesitate to use the first dose. The most common reason why steroids aren't given in women with preeclampsia is because they weren't given on admission, and people forget to give them or run out of time to give them prior to.
So I have absolutely no qualms with the clinical advice to give antenatal corticosteroids to somebody with suspected or actual preeclampsia. No problem. I just there is some data, and I think WHO and the Concept Foundation have synthesized that data to suggest that repeated doses does have a potential long-term neurodevelopmental impact. So whilst you may need to use it and you may want to use it, I think it's important to bear that in mind as a clinical feature.
Yeah, no, it's a debate.
I just want to add, both of you, currently the action trial we are doing with the WHO, with the multi-center, that will answer. Till then, let us wait on this. But I want to bring certain notice to regarding the steroids in LMIC. That betamethasone, what we are using, is not having the acetate and phosphate components. Especially in Indian context, we have only the phosphate. So acetate component, which is the long acting, is not there. So 6 milligram of acetate and 6 milligrams of phosphate, betamethasone is the ideal one to use 2 doses.
Yes.
So that is why in Indian context, the government of India has not recommended betamethasone. It has recommended dexamethasone for this reason. If you want to use, and even that betamethasone dose, sir, it is actually very high. They are doing now study we are doing with betamethasone 12 milligram 2 doses versus 2 milligram 2 times is what we are working on that. As you rightly pointed, there are some increased morbidity and mortality. When we observed this antenatal corticosteroid trial was published in Lancet 2014, we brought up that there is an increased sepsis in mother as well as in the babies who nobody had looked even in leggings, New Zealand man, but that what babies who were not born preterm after giving steroid, nobody had looked even in NIH study in 90s, it had not seen. So this antenatal corticosteroids trial brought that issue. Those babies who did not deliver preterm, they had increased morbidity in the form of sepsis. Right. So that led to, otherwise WHO and the other agencies were ready to operationalize and the trial there. And because of these effects of these, it withdrew that and did this, efficacy trial, which was published recently. It is efficacious, and American also there was one study done which also showed that steroids do benefit. Yes. But whether to give beyond 34 weeks, there is a trial going on.
There's Action 3.
Yeah,
it's a Gates funded trial.
Yeah. So I'd just say that the problem with the first steroid trial in LMICs, the women were not dated. And so that was the reason we actually developed the Tracer platform to do point of care transcerebellar diameters to date pregnancies any or everywhere. So that is, there's a big question mark over that trial. Clearly, steroids at term shouldn't be given.
Just a point on this.
Dr. Ballard, that the benefit outweigh the thing, they say up to 22. Not at term, and other.
So the benefit pre-34 weeks is 34 weeks. The benefit post-34 weeks is still question mark. And that's why the Action 3 trial is testing the use of steroids between 34 and 36 plus 6.
No, Madam is let her complete. Madam, last question from you as a moderator. We'll give the time for the audience later.
In relevance to same role of Maxself as a neuroprotection, 34 weeks after 34 weeks, can we discuss that also here? Because along with Dexa or Beta-Vithazone, whatever we are giving, should we give that at least one dose of Maxself for neuroprotection?
Yes.
Is there any role?
Yeah, beyond.
So the current meta-analysis would imply that it should be given up to probably 34 and 6. In Canada, when we wrote the guidelines, we were moved down to 32 weeks by the oversight group. But those of us who were the authors felt it should go up to 34 and 6, which is the same gestational age as steroids, and therefore it's easy for a clinician to remember. Careful review of those data, more recent data, have put some question around the utility of magnesium sulfate. But in a woman with preeclampsia whom you're delivering at 24, 25, 26 weeks, magnesium sulfate is probably going to be administered anyway. One dose, at least 20 minutes prior to delivery, is as effective as an ongoing infusion. So you only need to give it once according to the American trial, if you use it.
Yeah.
Sorry, madam.
But not beyond 34 weeks, madam.
Yes.
Yeah.
Yes.
Yeah.
Yeah, but you can just get, if you're worried about neuroprotection, you can just give a dose.
Neuroprotection, it can be safely given.
Yeah.
See, then,
currently there's no harm.
lower middle income group, Dr. Bellard has been a part of this CLIP trial. Can you just say, because the CLIP trial was mainly done in the India, Pakistan, and Zambia and Nigeria. Okay, what was the outcome of that particular study?
Actually, the objective of the CLIP trial is it's a community level intervention to reduce. See, these are the developing world where our maternal mortality has to meet the SDG goal. See, the Tamil Nadu and some of the advanced states are on par, like Kerala and all, they are on par with the developed world. But in general, this was an approach, in this, we wanted to shift the task from, because the nurse midwives numbers were less. So there was a cadre called as accredited social health activist. Asha worker was deployed, and this woman is actually helps to mediate the pregnant woman to take the hospitals, provide the care. But her service we used in CLIP trial as a person to record blood pressure, because that was a simple device which was MicroLife. With that, we used to say in a training that anybody can record blood pressure with this. So that is how the MicroLife device was. And she was given all the criteria and she was trained. Ashas were trained. Initially, the community was so reluctant to get the blood pressure checked from the Asha. But when we completed the trial, the same community said that you also provide some basic medication so that she can treat the common illnesses in the community. So that was the feedback we got. What we did is the women were identified. In India, because we have a MNH registry system, the pregnant woman was identified below 10 weeks. And this woman and these Ashas, 16 times they recorded blood pressure during pregnancy. I am very proudly saying this. That is 2 times postpartum, 14 times antenatally. They identified 650 pregnant women with hypertension. The contribution was 14,500. Out of that, equally half in the control arm and half, 7,000 out of that, 650. And this data has given, this CLIP trial has given the Indian data to the world, that what is the prevalence of hypertension in the community. What we give everywhere is hospital-based data. But this study has given that there is a 13% incidence of hypertension, out of which preeclampsia stands at around 3 to 5%. So this is what was done. They identified women, they recorded the blood pressure, and then when they identified hypertension, and this was given a mobile app with them, and based on that Mini-Pierce model, they used to follow these women, and when they are identified hypertensive and they were referred for a non-severe hypertension, they had a time of up to 24 hours. And these people were given the transport facility for the shifting these patients, and they were brought to the labor room where they should get, because we have seen the patients are throwing convulsions in OPD in some of the busy OPDs. So what we showed them was Asha worker to bring the blood hypertensive woman directly to the labor room of our hospitals and referral hospitals, and then the due care was taken. But if there is a severe hypertension, they used to give methyl dopa at their home, and identified nearby PHC, they used to take there and give the magnesium sulfate 5 grams to each buttock, and then they were brought to the referral hospital further. I am very confident to tell here, not a single maternal death, or even we saved almost all the babies where they're more than 28 weeks. And I must thank that for providing this clip trial to this part of the country, Peter, who was the PI on that side, and I was the PI on the Indian side. And unfortunately, if the study would have been extended for 6 months more from Gates Foundation, it would have really, unfortunately, we couldn't do that. It would have really given that. And today we would have had the task shifting of this blood pressure recording from the healthcare providers to the ASHA workers. And, if we want to really bring down the maternal mortality and perinatal mortality in India, it is the hypertensive disorder we need to tackle, identify, prevent, and then treat appropriately to meet the SDG requirement. Many states have already achieved that, but substantial reduction now is a challenge, and that is where all these predictive tests and effective management of antenatal blood pressure recording plays an important role. And that is how they were so proud. There were some of the incidences reported is ASHA workers were so much involved in the study. 210 kilometers from their place they went. When the mother got to their mother's place, this pregnant woman went to the mother's place. They went to her home, identified high blood pressure, brought them to one of the institute. I don't want to name that institution. They got there, and the patient and the mother both, baby and the mother both were saved. They have traveled 200 to 225 kilometers because their patient had gone to their mother's place. So these are the contributions the ASHA workers did on that. Actually, our DHO also was so impressed. He said, if you can get me the BP devices, I'm ready to purchase and give. But unfortunately, still till date, we are not having those devices